Thank you so much, the conference organizers, for inviting me. Interest of time, I'm going to be talking about lung cancer screening in non-smoking populations. So it's been alluded to a lot at this past few days here about lung cancer in individuals who have never smoked. And in fact, this is considered now the fifth most common cause of cancer-related deaths worldwide as of 2023. And here on the bar graph on the right-hand side, you can see that this actually is higher than colon cancer and prostate cancer. This entity of lung cancer in those who have never smoked occurs more frequently in women than men. It's been noted that about 15 to 20% of cases in the US are in those who have never smoked a cigarette in their life. The proportion of females who have never smoked with lung cancer varies worldwide, and I'll show a table that demonstrates that as well. And part of this is definitely because of various genetic and environmental factors that might contribute to this variation. Overall, over time, by modeling, we have seen that the absolute number and proportion of those with no smoking history are continuing to rise, in addition to that absolute number and a proportion of deaths related to lung cancer also increasing. How about lung cancer in Asian American women? In particular, for this entity of lung cancer in those who have never smoked, we see this in higher proportions in Asian women. Overall, it's quoted as more than 55% of Asian women are diagnosed with lung cancer in the US and have not had a smoking history. There have been two studies, mostly from California and in Hawaii, that were reviewing their medical records. The one that included Northern California and Hawaii reviewed almost 250,000 women. And from there, they actually noted that Asian women with no smoking history actually had a 1.5 to 2-fold higher incidence rate of lung cancer than all the other women that they looked at in their registry. In a different registry from Northern California, from the Kaiser Network, they looked at age-adjusted incident rates of lung cancer that they actually over time decreased among those with a smoking history and was relatively stable with those with no smoking history, except for the Asian American Pacific Islander adults, where the lung cancer incidence actually appeared to increase an average of 2% annually. And over here on the right-hand side, you can see this table that is showing, compared to the rest of the world, the top is many of our Asian countries. The navy blue represents women with lung cancer. And so certainly in the East Asian population, much higher numbers of lung cancer. Overall, lung cancer in those who have never smoked does have a different biology than tobacco-related lung cancer. For one thing, they're almost always non-small cell lung cancers and mostly adenocarcinoma histology. In addition, about 78 to 92% of lung cancers with no smoking history actually have targetable driver mutations. One of the most common is EGFR, which is detected in 20 to 30% of cancers, lung cancers globally. However, in Asian population is actually found to be about 40 to 50%. In addition, these types of lung cancers, their metastatic spread does tend to be associated with more brain metastases. So for EGFR and ALK, which is another driver mutation, for those who are diagnosed with stage 4 disease, 50 to 60% are actually presenting with or eventually develop brain metastases versus those with no mutations, where this has been reported to be about 16 to 20%. And another mutation that we see called ROS1, this is about 36%. To me, this definitely just underlines that, of course, catching these lung cancers or detecting these lung cancers earlier, hopefully can prevent the development of potential brain metastases in the future. Many of you are familiar with the TALENT study from Taiwan, which certainly has led the way in terms of lung cancer screening in a non-smoking population. Here, just to highlight that they enrolled over 12,000 participants, both men and women, although about 75% were women, and about 50% of the participants had a family history. They also had key inclusion criteria, which did include another risk factor for lung cancer, whether it was a family history of lung cancer, environmental smoke, secondhand smoke exposure, chronic lung disease. They also were calculating how much of cooking oils and vapors that the participant might have been exposed to, and also whether they were cooking without using ventilation. And so from their results, overall, their lung cancer detection rate was 2.6% for all of their participants, looking into the types of lung cancer that was detected, looking at just their invasive adenocarcinomas, their lung cancer detection rate was 1.5%. In the rest of the table, you can see how they broke this down by family history. And so they also saw that those who had a family history of lung cancer seemed to have higher lung cancer detection rates. As what you want to see in a screening program, the majority of the lung cancers detected were stage 0 to 1, as you can see here. And as many of you know, overall, these numbers were very impactful, especially when putting it in comparison to NLST and Nelson, which again were in those who had heavy smoking histories. And this led to Taiwan opening a national lung cancer early detection program, which not only is screening those who are eligible for screening based on smoking history, but they also have those with family history of lung cancer, but with no smoking history or light smoking history enrolled in their program. And what was presented just a few weeks ago at World Lung, for the non-smoking population, they have a lung cancer detection rate so far about 1.7% in comparison to their population with heavy smoking history of 0.8%. So here is a schematic of what we've been doing at NYU. So we've been running the female Asian non-smoker screening study, which has been based out of just one site at NYU. And our goal has been to enroll 1,000 women into our study. The only inclusion criteria is an Asian woman between 40 to 74 years old, identifying of Asian descent and no smoking history or less than 100 cigarettes in their lifetime. All the participants get up to 3 low-dose CT scans as part of the study, and each time they have a CT, we are drawing blood for a plasma-based cell-free DNA. We've partnered with Delphi Diagnostics for this. The scans are interpreted by lung rads, and the interval of when their next scan is based also on clinical judgment. And so here are the results. So we've enrolled all 1,000 participants into our study now at this point. And here you can see the distribution of lung rad scores from their baseline low-dose CT. Here you can see the majority were lung rads 1 and 2. And I'll just note that in NLST, the number of lung rads 1 and 2 were actually reversed. So about lung rads 1 was about more than 50% in NLST, and for lung rads 2 is about also around 30%, and I'll get to this point later. But overall, from just the first baseline low-dose CT scan, our lung cancer detection rate was 1.3%. A positive scan was defined as a lung RADS 3 or 4, and that was about 6.9%. About 2.3% underwent a biopsy or surgery. And you can see here that the majority of the lung cancers we detected were stage 1A. However, you do see that we did have some stage 3 lung cancers that were diagnosed as well. Unsurprisingly, they were all adenocarcinomas, and of note at the time of this data analysis, we still do have 14 participants with lung RADS 3 and 4 that have findings that are suspicious for malignancy, and they remain in follow-up at this time. Here's just a little more information of the lung cancers that we've detected in our program. There was one patient who had a lung RAD 0 and their baseline. They did have repeat scan as per the recommendations, which was upgraded to a 2. That scan is represented here on the top right. And this ultimately ended up being a stage 1 lung cancer with EGFR. All of the lung cancers that we detected on our study, all were found to have a driver mutation, majority of being EGFR, but we also had 2 participants who had a HER2 exon 20 insertion. There was one participant who had 2 nodules, and they actually had 2 different EGFR mutations. In terms of family history, about 15% only reported a family history in the questionnaire that we administered to them. There were 2 participants that on their 3rd low-dose CT scan as part of the study were diagnosed with stage 1 lung adenocarcinoma and another with adenocarcinoma in situ. The pictures in the middle there are representative of the stage 1A, that each year they were having their CT scan and was having a growing left lower lobe nodule. And then the second participant was someone who had a very strong family history of EGFR mutated lung cancer, had a ground glass opacity that she eventually did want to have surgically removed, and was found to be an adenocarcinoma in situ. Here's just a summary of our results compared to NLST and TALENT. Things to note from here is that the definition of a positive screen definitely varied between the 3 studies. Again, we followed mostly LungRad's recommendations, in contrast to TALENT, where their positive screen was defined as a solid nodule over 6 millimeters or a GGO over 5 millimeters, whereas per LungRad's, this would be a GGO of over 3 centimeters. Perhaps this does imply that there are different management practices between what's done in Asia and the US, and something that we need to think about as we go forward for screening these populations. At World Lung just a few weeks ago, Solstice was another screening program that was presented out of Singapore, where they have their program includes those with a smoking history, but also a non-smoking population with a family history for lung cancer. After about 2 years of screening, they have a lung cancer detection rate of about 1.9%. And interestingly, they were all in the non-smoking population. And they've also noted that the majority of the lung cancers that they found actually were found to have a LungRadS2 on their baseline low-dose CT scan. Which brings to, and it's been alluded to many times at this conference, about ground glass opacities and how this does present as a diagnostic challenge, particularly, in my opinion, in those with no smoking history. From what we saw in TALENT, where again a positive screen was defined as a very small ground glass nodule, and they were much more aggressive in terms of recommending potential surgical resection, they actually found that 1/3 of those GGOs were found to be invasive adeno, another 1/3 minimally invasive, and then another 1/3 with adenocarcinoma in situ. But it just goes to show that it's very difficult to determine what this could be just based on imaging. We looked at our ground glass nodules within fans as well, looking at the sizes of the GGOs, particularly within the LungRadS2 category. And they did the same in Singapore as well, that there are definitely nuances within the LungRadS2 category. So in summary, the feasibility of lung cancer programs for non-smoking populations is demonstrated by the 3 studies that I've talked about today. FANS, based here in the US, and to our knowledge, the largest dedicated screening program for a non-smoking population is 1.3%, which we do see to be comparable to what was done in Taiwan, which did have an extra selection in terms of another high-risk feature in the population. And clearly, we see that there are biological differences and presentations of lung cancer in those with no smoking history, which definitely suggests that different management guidelines for screening this population are necessary. And clearly, I do hope that we all will move forward towards one day having guidelines for screening a non-smoking population with other high-risk features. Thank you.